and welcome a growing list of guests today for the Statewide Biobanks seminar today. We are very, very excited to welcome Dr Matilda Haas from Australian Genomics. Matilda is joining us from Melbourne. And so look, just before I introduce Matilda, I think most people kind of know the drill with these talks. If you can all just stay muted until the end. Matilda's going to speak for about 40 minutes, but if you come up with questions during the talk, you're very welcome to just add them into the chat, and at the end I'll call on people, you know, in chronological order to ask questions. We should have about 15, 20 minutes at the end for discussion. So Matilda, who's joining us today, she's a program coordinator with Australian Genomics. I'm sure most people know about Australian Genomics and their mandate. They're informing the integration of genomic medicine into mainstream healthcare. And the research network is prospectively recruiting thousands of participants for genomic testing through 18 different rare disease and cancer clinical flagships. And so Matilda's background is she did a PhD in developmental neurobiology, and she did tell me that she did a number of postdocs, including an extensive postdoc in London, all of which where she was investigating genetic causes of underlying brain disorders before moving to Australian Genomics in her current role. And so today, Matilda, so in her role, she leads the development and implementation of the online dynamic consent and patient engagement platform that's called Control. And Matilda today will focus upon the Control platform and how these approaches can support research initiatives such as genomic research and biobanking, but also discuss their value in maintaining recruitment during the pandemic. So just a reminder to people, if you're not muted, jump on mute, and forward to hearing from you for questions after Matilda's talk. Matilda, thanks so much again for joining us.
Yes, okay, great. Thanks, Jenny. And thanks for the invitation to share some of our work today. As you said, I'll be focusing most of today's talk on the controlled dynamic consent platform that we've developed over the last 3 or so years in Australian Genomics. And right at the end, I'll also just talk about some other eConsent initiatives that we've developed a little bit more recently, which include the Mackenzie submission platform for recruitment into the Australian Reproductive Carrier Screening Project, and also an eConsent methodology that we've introduced for the consent into our clinical flagships. So as you mentioned, I work with Australian Genomics, which was funded in 2016 by the NHMRC on the backdrop of this rapidly emerging understanding of the power of genetic and genomic information and how it can be applied to healthcare across, you know, the healthcare and life journey. It can be applied right through from prevention to early diagnosis of genetic disorders, through to surveillance using the information from polygenic risk scores, and can also guide precision medicine or therapy. So since that time, Australian Genomics has grown to be a network of more than 80 organisational partners involving 400 individuals who are all contributing to a program that's driving the research and evaluation needed to support the implementation of genomic medicine into the Australian healthcare system. So Australian Genomics research can be divided into 4 distinct programs. This is quite a busy slide to put up as slide number 3, but just to point out that there's 4 programs, each with quite different research remit. So the Diagnostic and Research Network is taking an Australia-wide approach to developing the processes and pathways to deliver genomic medicine efficiently and to a high diagnostic potential. The data program is working out how best to use, store and, very importantly, reuse genomic and other associated clinical information. The evaluation and policy and ethics program is ensuring that the research is translated into policy and practice, but also doing research into the breadth of ethical, legal and social issues associated with mainstreaming genomic medicine. And finally, the workforce and education program is assessing how the genomic workforce needs to be appropriately scaled up and educated to deliver genomic medicine. So these 4 programs of work really rely on the information that's coming in from our clinical flagships. So the clinical flagships that we recruit participants into fall into 6 different cancer flagships and 12 different rare disease flagships. And we also have more recently undertaken the administration of the Mackenzie's Mission Reproductive Carrier Screening Project. So in Australian Genomics' current phase, the total planned recruitment is up to 25,000 individuals for genomic sequencing. So just a little bit more on how the clinical flagship projects work. They're all designed a little bit differently in terms of technology application and maturity, depending on where they were at when we first started the program. But they all have some common elements in that participants are prospectively recruited. We apply genomic testing while capturing health costs and asking participants to undergo surveys and other evaluations. And all of this research goes into identifying the impacts of genomic testing in healthcare. So that's everything from determining diagnostic rates to how often we were able to, for example, change management or treatment, what this information provided to patients about their ongoing choices. So when we started this research program, we underwent the ethics and governance, the human research and ethics and governance processes, as all human research projects do, and we developed the protocol and a suite of participant information and consent forms. So our first developed PICFs were up to 18 pages long. Now, we were quite concerned about the length of these consent forms, but it wasn't just about the length, it was about the density and complexity of the information in the consent forms. So with genomic research, you are really obliged to inform participants about all the things that are really important in terms of risks and benefits for genomic research. So you have to tell participants about the uncertainty of whether they're even going to get a result, the implications for their family members, the chance of identifying additional or incidental findings. There's also implications for access to life insurance products. And of course, we need to gain consent for data sharing for future research. So we questioned whether participants would be able to retain all of this study information in one recruitment and consent appointment. And we're also becoming really aware of these concepts of giving participants the right information at the right time, giving participants an opportunity to revisit information and ask more questions, and also to have opportunities for ongoing engagement with the study. So we thought that there must be a better way, and started looking around for ways to improve upon current standard research consent practices, and we learned about dynamic consent. So we've come to work quite closely with a team who first introduced the concept of dynamic consent, which is Jane Kay and her colleagues who are at Oxford and now also at Melbourne University Law School. And while they don't really like to put strict definitions on dynamic consent, I've sort of taken one from one of their papers here just so that, just to give you a bit of an idea what it involves. So they say that dynamic consent is personalised online consent and communication platforms that provide a consent mechanism as well as a means for ongoing communication. And they use an information and communication technology rather than paper-based consent. and it's participant-centered, granular, flexible, and adaptable. So there's, so as I mentioned, they don't like to put too strict a definition on dynamic consent because that would be limiting. But there's a few things that really a dynamic consent approach has to take into account, and they're listed in the dot points here. So participants really need to be able to review and make changes to their choices about research participation in real time. And because of that real-time factor, it really needs to be delivered in a digital online format. Dynamic consent platforms should give an opportunity for two-way communication between participants and researchers, and also provide a tool for being an ongoing patient engagement platform. And interestingly, while dynamic consent was initially put forward to answer an ethico-legal question around consent, the really early pilot studies with participants showed that the potential for dynamic consent platforms to deliver patient engagement strategies was actually highly regarded by participants, and so it kind of became embedded in the dynamic consent framework quite early on. So another thing I wanted to point out before we go too far is that dynamic consent is not necessarily an alternative to a broad consent. So what I mean by that is that because dynamic consent can deliver granular consent options, it's often there's a misconception that dynamic consent is exclusive of a broad consent approach. So asking participants for a broad consent to future research projects using their information or their samples. Dynamic consent is more of a delivery platform rather than a type of consent. So I won't spend any time on this slide because we'll revisit a lot of these points later, but I just wanted to point out that we did a lot of research around the dynamic consent approach and found that there's not only predicted benefits for patients using dynamic consent platforms, but there's also some really good predicted benefits for research groups and organisations who undertake these approaches. So just on the controlled design and development process, I have recently submitted a manuscript which we hope will be published soon on the design and development process, and I've distilled that all down into this one slide today because I don't think it's the focus of this actual talk, but I just wanted to point out just some of the key points in terms of the design of the control website. So in mid-2017, we established a very multidisciplinary working group to deliver on this project, and that included actually two consumer representatives and one patient advocate, and the group membership's usually been around a dozen people, and that some of that team is still the original team that started in 2017. The working group started with a mapping exercise looking at published and grey literature of instances of dynamic consent to get a feel for what we wanted our dynamic consent platform to look like and to do. Then we pretty early on engaged the digital health technology developer Curve Tomorrow to deliver on the project. And Curve Tomorrow undertook their own research. So they're very much focused on making a product that is usable and attractive to the end user. And so they did their own user experience testing, which involved interviews with 6 representatives of the major stakeholder groups involved in the project. So after the design phase, after the research phase, Curve came to us with a design and wireframes. And then when everybody who was involved in the working group and the stakeholder interviews provided feedback, they started the web build. They used a development sprint method, which is really important because it meant that any things that weren't so great about the design or any bugs or anything were picked up straight away, and users were testing the website throughout the build. We concurrently developed the written content with a very strong plain language focus, but we also needed to harmonise the control platform with our already approved patient information and consent forms, and also the national clinical consent form that was being developed by Australian Genomics at the time. That last point about HREC approvals, I put that in after Nick Zeps's talk last week because there was a bit of talk around eConsent and HREC readiness for approving eConsent, and he talked about the CTIQ report, which suggested that people think that HRECs aren't really on board with eConsent, but we think that's probably a perceived barrier rather than a real one, because Australian Genomics is a multi-site project. We deal with 5 different HRECs around Australia and 32 different governance offices in our recruitment sites, and we've had the use of control approved through those sites pretty easily, I would say, if we provide them with the right information. So this is just a very basic schematic of the site, a website map that I've constructed here. So essentially, participants register for the site and they're then taken through a 5-step consent wizard, which involves watching an animation, providing consent to have the genomic test done, consent to the research program, then indicating preferences for return of results, and finally giving us an idea of their consent around future use of their samples and information. After that consent wizard, they're directed to their dashboard, where they can then access the Contact Us form, an area where they can keep their personal and contact details up to date, and also a section for news and information. On any subsequent logins, the participant is directed straight to their dashboard, but they can re-enter any of those 5 consent steps shown in green there from the dashboard. So I'm just going to show you some screenshots from the platform now. So this is the home page. While we like to keep the control website just for participants registering in the program, we have developed a copy of this website, and it's available at demo control at australiangenomics.org.au, and that's specifically for anyone who wants to log in and have a play around with the platform to do so. So if anyone's interested in getting some details about how to access that demo site, please do get in touch with me. So this is the registration page. We wanted to keep it as simple as possible and mostly to information that participants would have at hand rather than having to go searching for. The only thing really that they need for the registration that they wouldn't know offhand is their study ID, which we email to them with the link to the control platform. On the right there is just a screenshot of the animation that I referred to, which tells people why we're trying to develop an online consent approach and dynamic consent approach. And you don't need to log into control to see that animation. You can also watch it on YouTube if you're interested. So this is what the website looks like in terms of all of the pages that ask participants to provide consent. So you can see on the left here that we have a series of short statements that a participant can check off as they go through the consent, and this was really designed to cut down the walls of text that people usually see in consent information, but also giving people bite-sized pieces of information that they can review, decide that they understand and agree to, and check off and move on. But they can also tailor the consent process to their own needs for information, because all of the I understand statements and all of the questions throughout the platform have this I button next to the statement, which they can click and expands, giving them further information. We also use a series of pop-up boxes, which you can see a couple of on the right there, to just really confirm with participants that they understand what they've agreed to and also what the next steps will be in relation to what they've chosen. This is the page where participants are asked to give their preferences for the return of research results. This is a different format of question where they can select yes, no, or not sure statements. And the not sure in this platform is always considered a no. And participants can always indicate that they'd like a bit more support with making these decisions by leaving this box unchecked at the bottom, which says that they'd like a genetic counsellor to contact them. So this step is the consent for future research use of their samples and data. So Australian Genomics participates in the Global Alliance for Genomics in Health, which is the international standard-setting organisation in genomic data sharing. So GA4GH's data use and researcher identity workstream has developed a data use ontology technical standard, which is essentially a series of data access codes that can be applied to research cohort data sets to describe use data access and use permissions in machine readable formats. So we applied those Duo access codes in the development of the questions for future use of de-identified samples and information in this platform. So you can see the top set of questions is about who can have access to samples and information and what kind of research that they can do with that, those data. So the reason that we wanted to apply this standard is mainly because it removes any ambiguity about the meaning of consent clauses, but also because by applying these access codes, it will really facilitate future interjurisdictional and international data sharing. Our application of the Duo, though, is I think the first of its kind, because rather than applying these specific access codes related to each of these questions to whole cohorts of data, we're applying them to an individual's data and therefore fully individualising the consent to future research. So on the left is just that set of questions again, because I just wanted to point out that we think this is very time-sensitive information. So rather than having this stored in the database that's linked with the control website, we actually have it integrated with our REDCap study database. So if a participant clicks not sure about sharing with not-for-profit research organisations, that's almost immediately reflected in the control instrument that's been built into the REDCap database profile for that particular participant. So what this means is that if our data team gets a data access request, they can at any time easily go and query the REDCap database to determine what kind of cohort that they could prepare based on the sharing preferences of particular people around what kind of organisation can have access and what kind of research they can do with their data. So after all of the consent is completed, a participant lands on their dashboard. As I mentioned, they can access a personal details section, a contact us and use information sections from the dashboard. And this section really outlines a participant's journey through the study, numbered in order of tasks that are due to complete or not yet available. So you can see that this particular person called testing has reviewed all of their consent, which they can go into again at any time by clicking edit. But their next task is to complete the participant survey 1, but that's not yet available. And when it becomes available, a do survey button will become visible here. And finally, the news and information section in the platform. This is actually a WordPress blog that is mirrored into the site. The reason that we've gone down that route is because I can regularly refresh the information materials in the WordPress site, and then it is mirrored straight into the platform without having to involve the developers or our IT department to deploy new versions of the website. And just a bit of a plug for Genomics Info, a lot of the stories that are appearing in this blog at the moment are actually borrowed from another project that's been going on in Australian Genomics, which is the Genomics Info website, where patient-friendly, easily understandable materials about genomics are collected together in a series of articles and infographics. So just to point out that control is also mobile responsive, and given the amount of information that's housed within the control platform, I think it looks actually pretty good. Here's a series of 4 screenshots from a mobile phone. I also wanted to point out that in our development of control, and the research that we put in before starting development, we actually identified quite a few different, I guess, aspects that a dynamic consent tool could cover, or things that a dynamic consent tool could do. And we've actually only implemented the top few here that are in the shaded blue box. That there's many other applications of dynamic consent that for us either still being considered for inclusion, as we get the resourcing to do so, or as the participant cohorts change and certain features become more important for different cohorts. And so finally, I touched on this before, but we've had the use of control approved by the HREC to apply to the Australian Genomics clinical flagship studies. And that approval allows us to recruit participants in 2 different pathways. Pathway A essentially is where a person goes through the normal face-to-face recruitment and consent appointment and signs a paper-based form. But during that appointment, they're asked whether they'd be interested in signing up for control to make, for example, more granular consent choices and have ongoing access to the consent. And if a participant indicates that they're interested, they receive an email with their study ID and the link to the control website, where they can then undergo that self-directed consent process. The other pathway that has been approved is that a participant still has their face-to-face recruitment and consent appointment, but they actually work through the control platform with the genetic specialist who's recruiting them into the study while receiving a paper-based information sheet. So in reality, we're only really using pathway A at the moment. There's been some barriers to starting off with pathway B, and they include things like lack of access to tablets and other IT equipment for doing it in the clinic, and also probably at this stage a lack of familiarity about the control platform and all the steps and information in it from the people who are recruiting into the study. So through the last maybe 5 to 10 years, there's been quite a lot of literature coming out around dynamic consent and the potential risks and benefits to applying a dynamic consent approach. So I thought it was worth just having a bit of a discussion about those here. So in terms of the participant, it's thought by many that there's more benefits than risks to applying dynamic consent, and that those benefits include giving participants a greater autonomy in decision making and more control over the terms of their participation, and that may increase the number of people who are willing to participate in research programs like genomic research and biobanks. As a result of the ongoing engagement afforded by dynamic consent, participants may gain a better understanding of the research, and as a result have increased trust in the research program that they're involved in, but probably all medical research. At the same time, there's been kind of literature developing that doesn't agree with the dynamic consent approach, and it lists a couple of main reasons as to why it may not be best to use it. And I guess the first and overwhelming one is the feeling that participants might be overburdened by ongoing communication and ongoing decision making associated with research, and that some people might like to just provide a one-off consent and then forget about it. There's also a concern that the dynamic consent approach shifts those governance and ethical responsibilities onto participants, and that really it's research organisations that should be making those decisions on behalf of participants. There are also potential risks and benefits to research organisations employing the approach. So, you know, we've been very interested in the benefits of dynamic consent for our purposes as well. And some of the benefits include better records of consent. So if your consent is kept electronically, of course, you know, it's going to be easier if you have to locate a specific person's consent choices to search those electronically, rather than, you know, go to a filing cabinet and be shifting through thousands of paper to look for a specific consent form. It can incorporate clearer data sharing frameworks, and I think, you know, we've demonstrated that nicely through the application of the duo access codes that I talked about earlier. There's a little bit of evidence actually to suggest that participants who are engaged in research because of dynamic consent platforms show increased completion of research tasks. So in the Rudy study that was first to apply dynamic consent, they found that actually as the study went on over 6 to 12 months, participants were actually completing more of the patient surveys that they were asked to, rather than less, which is usually the case in long-term research projects where survey completion is a big part of it. There's also potentially, because of the ongoing engagement and trust aspects of dynamic consent, there's also a predicted effect of people's increased willingness to participate in future research programs. And, you know, that's only good for research organisations who are looking for people to participate. And finally, another benefit could be the ongoing communication and, you know, the access of research organisations to up-to-date contact preferences, for example, allows follow-up in long-term research projects to be much easier than sending out letters and trying to locate people. So there's also been some identified risks to employing dynamic consent, and they include the startup costs. And, you know, there's absolutely no doubt that it does cost something to implement a dynamic consent approach, especially if you go down the route that we did, where there was a lot of research done to ensure that the experience of the end user was the best that it could be. So that's why we're really keen to share control with other research programs to reduce the startup costs for others. There are, you know, likely to be barriers to implementation, and they could be barriers in terms of people and process. They could be barriers in terms of lack of access to IT, as I discussed before, or even things like not very good systems available in hospitals, for example, you know, Wi-Fi blackout spots and that sort of thing that can really cause a barrier to using this kind of technology. There's also a predicted increased administrative burden, mainly through that individualising of ethical review, I guess, but also through, you know, delivering this two-way communication with participants and news and information, and this whole engagement strategy, of course, requires somebody to do that. So you'll notice that, you know, when I spoke well, probably through the whole talk, but particularly in those last 2 slides, I talked a lot about predicted benefits and proposed benefits, because what is actually really much needed here is a proper and formal evaluation on dynamic consent. So we published a paper last year calling for projects to trial the dynamic consent approach and develop a really well-designed and robust evaluation alongside those implementations of dynamic consent. This is sort of really lacking in the field, and dynamic consent is really still a bit theoretical, and applications are quite rare to come across. So we're contributing to this evaluation with our current clinical flagship projects by a number of routes. We'll be looking at sign-up rates for those people who've been offered dynamic consent. We'll be looking at the Google Analytics, so all of those questions around how long people spend on the website, how often they return, what their exit pages are, all of those sort of things. We're also building questions into participant surveys so that we can find out about people's experience in the research program, whether they're in the group who are using control or are not using control. And those questions are really centred around satisfaction in the research, trust in the researchers, and those sort of things. And of course, we're also looking at the consent choices that people are making, how often they're updating them, and what they're making their changes to. So just a little bit on the impact and translation of the control platform. Several Australian research groups are considering adapting control for their use. We've also had considerable interest internationally, particularly from the World Economic Forum and the GA4GH, which I've spoken about earlier. Control has already been adapted and built upon for the Mackenzie's Mission Australian Reproductive Carrier Screening Project, which is recruiting 10,000 couples and started recruiting through their platform at the start of 2020. We've done some pretty rough calculations, but for the Mackenzie's Mission portal at least, we predict really significant cost savings by using this sort of online approach to consent, and those cost savings could be in the order of hundreds of thousands of dollars. So, of course, the commercialisation potential of control has been discussed, and we are definitely interested in following down that route. However, what we really need to do is provide evidence of the value across user groups, and the evaluation that I referred to on the previous slide will really be a good start to demonstrating that value across user groups, but we also need to demonstrate the value for research organisations and research groups as well. So that's our main focus at the moment. I just wanted to spend a very short amount of time talking about dynamic consent more in the context of biobanks. So dynamic consent has been raised as applicable to biobanks quite regularly, and most of all probably to address this issue around broad consent not being informed consent. So there's quite a large and I guess a robust literature out there around whether asking people to participate in research with broad disclosure around what projects their data might be used for or their samples might be used for in future doesn't constitute informed consent, because by the traditional definition of informed consent, you have to give people quite detailed information and information about the risks and benefits of the individual study. So dynamic consent has been suggested that it could be applied to biobanks to allow the opportunity to gain consent for every single project that a person's samples or data are shared for. So I don't personally have any very strong opinions on this, because I know with biobanks that usually there's some very strict frameworks developed around what kind of future research can be done with people's samples. But, you know, if people want to talk about this more in the discussion time, I'd be interested in people's thoughts. But just, you know, a little bit, while we're really not ready to start talking about the results of our use of control just yet, what I will say is that we don't ask people to consent to every new research project that we're going to share their samples or data with, but we do ask them in the control platform to know about it every time their samples or data is shared, you know, some details about their project that it's shared with. And almost every single person who's signed up to control has said yes, that they would like to know what their information is being used for. So I think that that's really gives us some information about, you know, what people really want on this issue. So dynamic consent platforms might also result in a greater willingness to participate because of transparency and information and all of that ongoing engagement that I've been speaking about. Dynamic consent could also increase participation in biobanks from underrepresented groups. So this can include, you know, the things that we've heard about that dynamic consent can deliver, for example, quite easily language translations. They can allow you to reach a greater geographical population. But also, Megan Prichter wrote a really great paper a couple of years ago on this, using dynamic consent to increase participation. And she also talked in that paper about things like using dynamic consent to gain community consent rather than individual consent, for example, in Indigenous populations. Dynamic consent can also help to streamline the return of research results and incidental findings if biobanks are delivering those, and to know participant preferences about receiving such results. And dynamic consent can also allow people to review decisions about participation in a biobank. So, you know, obviously not all biobank participants, but some would be asked about their willingness to participate at an emotionally disruptive time, such as going into a surgery, and dynamic consent could allow people to revisit those decisions. I just wanted to include this because I thought it was really interesting. So when dynamic consent was first introduced, there was a little bit of research that suggested that while participants really liked the fact that they could make changes to their choices about consent if they wanted to, that in reality they found really very little reason to do so and kept their preferences quite stable over time. So that's why this new research that came out from the Mayo Clinic Biobank in the US came out in April, just gone. They assess the stability of biobank donor preferences. So in the biobank, when people first enrolled at time 1, they asked participants whether they would like to make their sample available to family members in the event of their death for DNA testing if their sample was required for that purpose. And about half of the people that they sampled permitted the use of the sample for that purpose, and about half restricted. In a theoretical survey that was sent out at time 2, which I think was about 6 or 12 months later, they didn't tell participants how they answered the question first time around, but they asked the participants the question again about releasing their sample to family members. And interestingly, most of the people who permitted the first time also permitted at time 2. But the thing is, you know, a lot of people who restricted the first time actually changed their choice so that they then became permitters to use of their samples after their death. So I thought this was really interesting for 2 reasons, because one, it suggests that people do change their choices over time. In this study, you know, around half of people did. But also that people may become more willing to give more of their samples and information over time the longer that they're involved in something like a biobank. So just very briefly in the last minute or two, I'll just touch on some of the other applications of eConsent to the Australian Genomics programs. So I mentioned earlier that control was built and expanded upon for the Mackenzie's mission study. So this is the Australian Reproductive Genetic Carrier Screening Study that's being administered by Australian Genomics. And so in this study, after initial consultation with a health practitioner, couples are given a time-limited access code that they can use to access the Mackenzie's mission portal for the first time. And the portal covers really all aspects of their participation in the project. They can use the portal to assess their eligibility for involvement. They can undertake an educational component, provide their personal and contact info, and their demographic info. They can also undertake research participant surveys, use an optional decision aid to determine whether they should become involved in the research program. And they can even order their test kit to be sent to their house to provide their sample and send back to the lab. And importantly, there was the inclusion of that set of questions that I showed you in control around future use of their data for research. And in another more rapidly developed example of eConsent that's been put in place by our flagships is the remote recruitment and eConsent strategy. So specific flagships in our program were noting low recruitment numbers due to remote and rural eligible participants that had been living with their condition for a long time and didn't necessarily come into clinic very often, which is where the study recruitment takes place. So to address this, a process was designed whereby a person who was eligible and interested in participating had the information materials mailed out to them and a phone appointment scheduled with a genetic counsellor. During that phone appointment or telehealth appointment, the genetic counsellor seeks interest in the person completing consent online during the appointment and sends a link to the eConsent form to the participant via email. So this is actually a survey instrument that's been built in REDCap. And so this process was being approved through our HREC right at the time that the COVID situation was ramping up. And so it's actually also been highly valuable in maintaining study recruitment targets in a situation where patients either don't want to come into hospitals because of concerns about exposure to infection with COVID or because non-urgent clinics have been cancelled. So this is just a couple of screenshots from the eConsent. As I said, it was built in REDCap, but you know, looks quite attractive. But you know, using REDCap to build something like this is quite, you know, fast and it's cheap and it's easy for researchers to do. And you can see that this form has also employed that idea of making a few short dot point statements that a person is asked to work through and agree to the points so that there's not that big chunk of information at the end to agree to. So I think I've gone much further over time than I thought I would. But just to acknowledge, you know, the core set of people who've been involved in this work, particularly the Dynamic Consent Working Group, our data team, and of course, Kerf Tomorrow, who developed the control platform. And yeah, just a call out to anyone who has, you know, questions or comments after today to please get in touch, and as well if you'd like instructions to access the demo control website, or if you have interest in applying control to your research program. So I shall leave it there. Thank you.
Oh, thanks, Matilda. That was really great. Yeah, so informative, and I think you know, congratulations on developing a control program. It looks wonderful. Now, look, I'd like to encourage people, if you have questions, please just pop your name into the chat. But while we're waiting, I guess my main question was just around non-English speakers.
Mm-hmm.
So, I mean, clearly you can see how eConsent is really helping in terms of, you know, sort of geographic consenting or geographic barriers to consent, but just in terms of the language. Have you translated control yet into any community languages?
We haven't yet. I guess that's sort of, so we're kind of preparing for the next stages of development of control. The first thing we want to do is build an administrator side to control so that changes can be made by researchers to the wording of questions and that sort of thing. But the next big focus would be on language translations. And we'll have a bit of guidance in doing that because the Mackenzie's mission portal is currently being translated into 3 other languages other than English. And so that will be really good for guiding us in the future. But yes, that's certainly something on our agenda.
Oh, thanks, Matilda. Toby, I can see you've got a question.
Yeah, thanks very much. And thanks for the excellent talk, Matilda. Control seems like a very powerful tool and something that really does take into account the differences in various cohorts that might be targeted for various research projects and how to engage more of them. I'm currently involved in developing an eConsent solution for New South Wales Health Pathology as part of our COVID-19 biobank. And one of the things that was identified from just the initial framework and design that we put to HREC committees was firstly the security of the information that was being captured, but the other part which led to us developing a fairly complex security arrangement was the necessity to provide a completed consent form to the participant once they had actually agreed to this. Now, where dynamic consent is concerned, that completed consent form is likely to be updated any time that the participant interacts. So I guess that there are 2 kind of questions. Did you have any specific guidance from HREC about ensuring that the materials were returned to the participants? And were there any identified complexities in providing updated materials to that participant on an ongoing basis when they engage with the module?
Yeah, they're really good questions. So the HREC didn't have too many questions for us around providing, say, for example, a PDF back to participants, because I suppose for 2 reasons. One, because they were given a paper-based consent form which they initially signed, and that control is sort of at the moment being implemented as an add-on consent step. So we're kind of taking the softly approach to implementation of control. So I think that would have been one of the reasons. And also because I guess the re-access of control at any time provides that record for a participant about what their choices were. At our end, we have certainly developed, aside from that direct integration of some of the information in REDCap, we've developed other approaches to having a complete record of a participant's consent choices in terms of, we receive daily emails about updated consent choices and new registrations, and we can query the back end of the control database as well. But certainly when we were developing control, there was suggestion around being able to build a PDF of all of those consent pages and to print it off. And, again, that would be something that we will be considering as future development, especially if we decide to go, move away from the paper-based consent altogether for our next set of studies.
Yeah, absolutely. Thank you.
Does anyone else have a question? Anyone who's online? We've got a few more minutes. Look, I just might ask another question just about the issue of trust in research from participants. Mm-hmm. Is there anything that's known so far about what are features of organisations that tend to engender participant trust?
That's a really good question. So I guess the not-for-profits and the universities engender more trust than commercial companies and potentially government organisations as well. Although, again, not wanting to refer too much to the choices that people have made in control so far, but we've actually been surprised how many people who have ticked the box to say that they're quite willing to share their information with commercial companies, for example. So I think there's sort of trusted organisations, but there's also, it's maybe around the characteristics of the person. And I know the Your DNA, Your Say study run by Anna Middleton is, publishing some really interesting papers around the types of people and the cultural backgrounds of people who are and aren't willing to share or donate their information for research. And quite interestingly, a paper that came out last year showed that Australians are actually sort of less willing and less trusting than their UK and US counterparts. So, yeah, it's a really interesting topic, and I don't sort of have a depth of knowledge in that area, unfortunately.
We have another question from Anusha.
Thanks, Jenny. Hi, Matilda. Thank you for your talk. That was really interesting.
Thank you.
I really like that that going back to the patient, to make sure that they're okay with the project that you're giving out information or samples for. The only thing that sort of struck me was what happens if you lose touch with the patient? People lose their email addresses, or worst case scenario that they do actually pass away.
Mm-hmm.
Do you just take the last consent as sort of the enduring consent then?
Yeah, so we don't actually have any formal plans to recheck in with participants to find out, whether they have moved on or unfortunately passed away. There is some talk about at the end of the current phase of our clinical flagship projects to recontact all participants to kind of make sure that their contact and preferences are up to date. And I think actually of dynamic consent platforms, that is one of the sort of other remaining operational challenges, is that if we can't link these consent platforms to electronic medical records or other sources of information, then, we may end up inadvertently sending out emails to, for example, complete surveys, patient surveys and things when it's, not appropriate because the person has passed away. So, yeah, I think that definitely is a remaining challenge. And where it shows where the genetic counsellor or the clinical team managing a person's care is sort of irreplaceable for access to that kind of information.
Yeah, absolutely. It'd be interesting to see how it works out.
Yeah.
Thank you.
Thanks.
Candice, do you want to jump in with the last question? I think. All right. No, Mike. I'll ask. Yeah, whether you've had an experience consenting children with the model. So this is from Candice Carter, our operations manager.
Yeah. So when we first had control approved through ethics, it was sort of like a bit of a pilot study to start with. And one of the pilot studies was one of our clinical flagships that is only really recruiting pediatric patients with child interstitial lung diseases. And so it would be the parents signing up for control, in kind of a slightly, not slightly, but quite distressing time. And we found sort of low sign-up rates in that particular cohort. We cannot use, we've developed a series of terms and conditions around using the platform, and children under 14 aren't actually allowed to use it themselves at the moment for consent. But, I think that example of parents not so much using control to sign up on behalf of their children, and we've had more success and interest in control from one of our cohorts where people are, sort of adult age and signing up for themselves. I think that suggests that the way our platform and eConsent is at the moment, it's going to be more applicable to certain cohorts than others, which is a shame. But, you know, with further resourcing and, you know, dedicated time on this project, we could certainly adapt the platform so that it's more usable to different groups and different age groups.
Yeah, well, look, we might wind up just given the time. Matilda, that was a wonderful talk. We had so many attendees. Thank you so much for joining us. And I think, you know, we might have you back next year to hear more about your research in terms of the engagement around control platform, because you're clearly doing a lot of really interesting follow-up in addition to developing the platform, you know, understanding how it's being used and how it's being rolled out. Congratulations.
Yeah, fantastic. Thank you. I'd love to.
Thank you. Thanks,
okay, thanks. Bye, everyone.
Bye-bye.